Hey everyone, welcome to a joint meeting this morning with House Healthcare and Senate Health and Welfare. And we have the pleasure of having Bi-State with us today. It is Bi-State Primary Care Association, and it is their day in the State House, which we always enjoy seeing everyone and hearing what you're doing. So we're going to start, I think, with probably a quick introduction and then bring some of the, I think we have 3 of the different FQHCs to come forward. And we'll just have a good conversation. So introduce yourself and.
Thank you. Good morning. For the record, I'm Georgia Maharis, Senior Vice President Policy and Strategy for Bi-State Primary Care Association, resident of Montpelier, very proudly, despite our very slippery sidewalks today. The roads are fine, though, if you walk on those.
That's what I did this morning, yes.
Thank you so much. As the chair indicated, we are hosting our legislative day today and are excited to bring some of our challenges and opportunities to this joint committee meeting. Also, if we're in the card room today, so you're able to stop by, please do. We have a little bit of a game and some jelly beans for those interested. So thank you for that. I'm going to be very brief. I'm just here to open us up, and I'm going to invite 3 of my colleagues from the community health centers of the Chittenden and Southern Grand Isle counties, the Springfield region, and Arlington, Vermont. So Jeff McKee, Kayla Davis, and Josh Dufresne are going to do the rest of the testimony.
And do you want to come up together, separately? It's up to you.
I think together might make the.
Yeah, there's 3 chairs. Great. Come on up. Thanks for coming in so early.
See what happens.
Yeah, that was fantastic. So, good morning. I am Jeff McKee. I'm the CEO of the Community Health Centers. We serve Chittenden County and Southern Grand Isle County. And I'm going to go first and just pass those around if you don't mind. A lot of facts and figures related to the community health centers. I'm not going to go over the whole list of things, but they're there for your reference. One of the things that I really want to make sure that this joint committee here this morning understands is that federally qualified health centers are different than other kinds of primary care and other kinds of health care generally. And one of the things that makes us different is all of our missions include a commitment to health equity that manifests different in how we deliver services. So just to, probably preaching to the choir, but to say the difference between health equity and health equality. Health equality, we all do that. We open our services to anybody. Anybody can come. Anybody can come regardless of their ability to pay. We all do that. And many healthcare organizations do that. That's health equality. We don't close the doors to anyone. Health equity challenges us to go further and to understand the barriers that different segments of our community have in accessing healthcare, which creates health disparities across the communities. And so in each of our missions, it looks different in every community because every community demographic is different. But all of us challenge ourselves to understand who is not getting served. So it's not just about the people who walk in our doors, which every healthcare organization tries to serve. It's those who don't, who can't, who won't, who are afraid to, don't know how, whose other conditions and social determinants of health prevent them from getting to us. So we have a variety of services that we offer to kind of get to that last mile of healthcare in our communities. And if we don't do it, nobody else does. Right? So that's the thing that's truly unique about federally qualified health centers. There is no one else doing this work, leaning into the work the way that we do. Part of our missions, as I said, and we are so proud to do it every day. This is not a complaint. This is just so you know who we are. We wake up every day living this mission. In the case of the community health centers, just to give a couple of highlights. So we're the state's only healthcare for the homeless program as well. So in Chittenden County, that means that we do a lot of work, working with people who are not our patients yet. Trying to do the outreach. We literally have people who strap on backpacks and walk into the woods and in encampments in tent cities, go to the motels and hotels and try to engage people and offer them care. As I said to Senator Lyons this morning, briefly, we have to now challenge ourselves to also understand our where we need to do things better with respect to substance use disorder treatment. Drug dealers don't make you take a bus to get 30 minutes away to a methadone treatment center, they show up at your door at home delivery, right? So where we're located, you look at us, we have 9 locations in Chittenden County. That's a lot for a small footprint, but we understand if we're not in those locations, people make other choices about accessing their healthcare, but it's too high. So we have that outreach program. Much of that care, even though we have a small grant to do the HH program, is uncompensated care. We do it because it's our mission to take funds that we have from other parts of the organization, and we subsidize that outreach into the community. That's vitally important, right? And across the state, but particularly in Chittenden County, in my opinion. We also have an elder care program. And our elder care program provides, we do house calling, and we help people age in place throughout the community. People who would otherwise access the E services at a much higher rate. And as you can imagine, when you're providing those kinds of outreach services that require travel, you're working with patients with multiple complexities, social determinants of health complexities, as well as medical complexities, and often with people who have not had their healthcare needs appropriately addressed for years. These are not 15-minute visits, right? Our model looks different and requires different kinds of funding. My clinicians can't see 15-minute appointments, rarely ever. And then you add to that the complexities of the outreach and the work that we do. It requires a different kind of funding to do that work. And we're grateful that the model we've been offered by the state or by the federal government actually supports that. If we lean into our mission, we will be okay. And if the funding is there from the states and the commercial payers as well to make it all work, we have a problem right now that it's not working, right? The funding is not there adequately to continue that. And in our case, last year we had this current year, we're going to likely have a $1.2 million deficit. We're starting to put together our budget for next year. I'm looking at a $2 million budget deficit. I don't know how to close that at this moment. I can't cut any more staff. We actually had layoffs last year. That's real. That's likely to happen again. And the programs that get cut are not the ones that have a revenue source attached that serve the people who are the most well-off in our community. The programs that have to get cut because the financial math only works this way are the ones that don't have a revenue source attached to them and are those all mission aligned and are serve our most vulnerable members of our community. So that's where we're at. And so I think the staff we have certainly have over 450 staff, or 350 staff. They wake up every day doing the work, and there's a commitment that I've made to them, and I always felt like the state of Vermont stood behind me. We'll figure out how to keep the lights on so you can do that work. I'm having trouble kind of saying that with confidence in the last couple of years. That's our story. I think Kayla's going to go.
Right, let's go right to Kayla. That'd be great.
Yeah, and I'm going to try to share my screen. Madam Chairs, members of the committee, thank you for this opportunity to provide testimony on the role of the health centers in our communities, how our services are responsive to the unique needs in each of our communities and their residents. My name is Kayla Davis, and I'm honored to be one of the co-executive directors at Battenkill Valley Health Center in Arlington. Much like Jeff pointed out, I want to talk about how FQHCs are different. We have rigorous requirements attached to the federal funding that we have to help support our programs. But we see the sickest patients, we see the patients with the highest level of need, while also being held to extremely rigorous healthcare standards. We cannot manage our payer mix, so many other healthcare entities can decide which revenue streams, so commercial insurance, Medicare, Medicaid, which visits are the most revenue generating and decide what patients to welcome. We can't do that. If we're open to new patients, we're open to all regardless of ability to pay, Medicaid status, and that is part of our mission. While the work is high in cost and labor, it's our mission. This is the work that the community health center movement set out to do all those years ago. BVHC is teeny tiny. We're located in Arlington. We have a little campus with 2 buildings. We serve just over 4,000 patients, and our payer mix is split about a third between Medicare, Medicaid, and the commercially insured. But 48% of our patients with known income levels are living at or below 200% of federal poverty. Our patients are different. This is why the sliding fee scale program that we offer as FQHCs is so important, because it ensures that regardless of ability to pay, people can access healthcare in our building. More than 25% of Bennington County residents are enrolled in SNAP. In fiscal year 23, BVHC distributed almost 1,700 bags of fresh food through a partnership with Veggie Van Gogh, 4,600 pounds of food from our food shelves, which are located in each of our waiting rooms. And that's supported through private donations and the Arlington area food shelf. Bennington County suicide rates, overdose mortality rates, and mentally unhealthy days are higher than the state and national averages. This is why we have 4 therapists on staff, a psychiatric nurse practitioner, why all of our providers prescribe Suboxone for substance use disorder. We're at a critical point in this state, and this work is so important, and people need to access it regardless of whether or not they can pay for it. Oral health care. Bennington County has a dearth of dentists, but for those who have Medicaid, it's even harder to access services. I think we are one of 3 currently, but SVMC's dental practice, I'm not sure if they're closing, will be one of 2 dental offices accepting Medicaid. We do that work in the office, and then we also go out into the community because we know that there's not access to dentists. So if we can educate children, parents, if we can get toothbrushes into the hands of these folks, it's something, right? So we're in the classrooms, we're in daycares, we're in public settings, we're in local businesses. And last fiscal year, we distributed over 3,300 toothbrushes into the community with help of private grants. Chronic conditions in Bennington County are high, and this is one of the things that sets FQHCs apart. We do population health management, and we try to teach life skills. So we provide walking groups, we provide free cooking classes to promote overall mental health and physical wellness, but also to help people develop those life skills that they may not have. And again, it's free. They get to take the food home, and they get a skill out of those classes. We have a partnership with Green Mountain Express. It provides free transportation to and from medical appointments, dental appointments, mental health appointments, to ensure that transportation is never a barrier to care. We're in rural communities. We are located on the Green Mountain Express bus line, but if folks have mobility issues that don't allow them to utilize the bus line, then we pay for door-to-door service. And we believe that teaching children about health at a young age makes a difference. We supplement the Arlington School District's healthcare curriculum. Our providers go in. It's a wonderful opportunity to lead discussions with up-to-date information. It exposes children to different healthcare professions at the same time. And in last fiscal year, we gave 27 health presentations in local schools and daycares. We're also working with GNAT, the public health or the public access television in Manchester, to do mental health and medical shows so that we can get information about ticks and different things out into the community. We're also committed to being part of the solution for the health professional shortage that we're experiencing in the state, and it's national, but the state of Vermont is experiencing it hard as well. We host interns from many different fields, but our proudest accomplishment is that 5 of the 15 dental students that we've hosted have stayed in Vermont. So critical. In summary, health center model is unique. We strive to be responsive to the needs of our individual communities. We work with community partners to reduce barriers to care and expand programming. And we are constantly working on ways to find equitable access to quality healthcare. Each health center serves a unique population, and we have unique costs. Our costs are growing at a much faster rate than our reimbursement. Like our peers, we're projecting a loss for fiscal year '24. In order to continue to do this work, we need to be receiving reimbursement that aligns with federal regulations. We are at a critical point with federal funds that have provided insulation over the last several years expiring. We have to find a way to assure that the safety of the community health centers is there to safeguard the care that 1 in 3 Vermonters currently receive.
Thank you, Kayla. Such good work. Josh?
Everybody, thanks for being here today. Thanks for listening. I'm Josh Dufresne. I'm the Chief Executive Officer for Springfield Medical Care Systems, is our corporate name. That may be familiar to many of you. We were in the headlines quite a bit back in 2019. We are now doing business as North Star Health, which is a federally qualified health center without a hospital. We did spin that off. We have 13 locations that are primary care, dental. We're actually in the schools as well. We do have a mobile unit that goes out and meets people that are homebound. We take care of approximately 25,000 patients, and we see about 100,000 visits per year. It's getting harder and harder to run my organization. Last year, we did have a loss. Coming out from bankruptcy, you can imagine that we didn't really have any reserves. All of those were pretty much liquidated. So we had to pull ourselves up from our bootstraps. What I'm seeing right now is a loss from last fiscal year. Our fiscal year starts in October. I've already got a $1.1 million loss this year from operations. So what I'm starting to look at is cash on hand, not necessarily operations, other than trying to improve it the best of my ability. And that's getting more and more difficult. Not long ago, Senator Sanders called me and asked me to spread the FQHC down into Brattleboro, into the Brattleboro region. And we've had some good conversation with those individuals in Brattleboro, and they want our help. The business plans aren't coming out in the black, and that's frustrating. We offer a huge amount of enabling services, whether it's behavioral health, whether it's the dental aspect, the primary care, or even vision care. We're one of the only FQHCs in the state that have 2 optometrists that help people get eyeglasses. If you can't see, it's hard to get a job. If you don't have front teeth, it's basically impossible to get a job. These are the types of things that FQHCs do. We are your safety net in the state of Vermont. And I can echo what Kayla and Jeff had said today. We are very proud to do the work that we do. We open our doors to everybody and anybody, regardless of anything. There's actually quite a long list, but anything, we open that door. We want to be sustainable. We want to take care of our patients. And one of the ways that I've been trying to revolutionize primary care in the area that we serve is to integrate lifestyle medicine. Some of you may have heard of lifestyle medicine. If you haven't, check out the American College of Lifestyle Medicine, ACLM. And we are taking care of patients by asking them how their stress load is. That's different, right? And this is in primary care. So how's your stress? How's your sleep? If you have a smartwatch, you might know what your sleep looks like, right? And you're like, I gotta do better. What's your nutrition look like? And how does that affect your sleep? How does that affect depression? Those meetings with patients take time. I'm paid primarily by volume. So I have to tell my medical staff, about 45 individuals, see more, see quicker, take less time. As a patient, that's the absolute worst case scenario, because I'm going to go into an exam room, I'm going to spend 10 minutes with my nurse or my MA, maybe 5 or so with my clinician. Did I get all the problems out that I needed to? No. And that makes it really hard. So what do? You reschedule the patient to come back in 3 weeks. They don't have a car. We have to get a van. We have to get a bus ride. And we get some help with that. We have some free couriers that help move people around. We did receive a grant during COVID. Ironically, if COVID happened when it did, we probably wouldn't have gone bankrupt due to the funding that came to the organization. That would have bailed us out at the time, so we could have taken care of a lot of things. But to be in bankruptcy and then also have COVID hit, that was a tough mountain to climb. I can tell you, just getting back online and having the operations go the way it did, we got some rain in July. That took out 2 of my clinics. So I had to shut down Ludlow Health Center. I had to shut down Ludlow Dental. Both of those locations were flooded up to the first floor and required complete mold removal, new HVAC systems. And in dental, the insurance company doesn't cover your dental equipment that's in the basement, such as suction, vacuums, those type of things. I did not make money on the flood. I thank the state of Vermont for their help, and many others that did help us, but we did not make any money on that flood. And that was very difficult for the patients. We did park our mobile unit out in the middle of Ludlow, and we were able to help people that needed immediate care. The last thing I want to mention is walk-in care, acute care. We do offer that, and it's much different than what I would refer to as urgent care, which is mostly a for-profit organization. For walk-in care, we take care of people that can't get into their primary care right away, which is a thing everywhere, it seems. There's not enough primary care folks, and that's because they don't maybe make the same as a specialty or a subspecialty. So doctors are going into those type of fields instead to pay off loans and debt. The walk-in side of what we provide is something that will allow people to then establish with primary care. We find a lot of people that that's their primary care walk-in, and that's not where you should receive your primary care. It's a necessary evil. We have to be there because it's keeping people out of the emergency room. For lifestyle medicine, we have reversed chronic conditions without pharmacy. That's huge. That's going to get cut if I can't be sustainable. I'll have to have lifestyle medicine, which is near and dear to my heart. Georgia can tell you I talk about it all the time. Will have to go away. These enabling services will have to be reduced. And the way that this structure works, you don't have more money if you're smaller, and it's harder to have more money if you're bigger. So it's not necessarily the model, it's the reimbursement. So I really want to thank you for listening, and thank you for all the help that you can provide.
Great. Thank you all and your colleagues for all the work you do for Vermonters. It definitely is vital. We have a couple of minutes if there's questions.
Can I talk
Yeah,
first?
absolutely.
So before we jump into questions, I just want to say thank you again on behalf of Senate and House Health and Welfare, and Health. And a couple of comments. Before we finish, it would be great for folks who also are here from FQHCs to introduce themselves. So we could go down the line, that would be great. But why don't we do that first, and then I have one more comment and other questions.
I'm Dr. John Matthew from the Health Center in Plainfield. I'm the CEO and medical director.
Chris Town, I'm the Chief Operating Officer for Northern Counties Healthcare serving Vermont's Northeast.
I'm Ronaldo, CFO for Community Health Centers of the Rutland region.
Thank you all for being here, and we're thinking that your colleagues have spoken for you in many ways, so we appreciate that. Just to say that your comments are extremely well taken, and certainly as we're going to be hearing testimony regarding Act 167, which is an evaluation of community needs and linkage of community services with hospital-based care and other care, that you are on the ground floor for this, and we appreciate very much that work. We work collectively and together on ensuring sustainability, in particular for primary care, as we work toward healthcare reform. So thank you for your work. So go to questions.
Alyssa.
And yes, thank you so much for your work. So I was wondering, in our budget this fiscal year, there's a big expansion of the Hub and Spoke, a 2-year grant. The Burlington Community Health Centers, you're the largest spoke. Although I guess I thought you were a hub, but maybe I got my hub. You're spoke. You're a spoke.
You're a spoke.
I'm wondering if you are seeing any of this yet, or projections of what you may be receiving
Yes.
from this.
So we are definitely expanding our services there, for in the spoke arena. And so the funding that comes through the blueprint and that funds the spokes will continue to expand that as needed. What we're really thinking about, though, is how we have to do that service different. The hub and spoke model was amazing. We were part of that. I've been around for a long time now. I was part of that from when it started, and it was a national kind of best practice. But the substance use profile in our communities has changed dramatically. And so patients that want to walk into a clinic and get buprenorphine, and whether buprenorphine in an outpatient setting is really is going to meet the need of people who are addicted to fentanyl and other kinds of opiates is is a different kind of a question. So we're grateful for the funding. We are going to see that. We are looking to expand the number of clinicians and support for that. But it's, I'm not sure that's getting at the problem we're experiencing, at least in Chittenden County.
Are you seeing the money yet, or?
I don't believe we've seen any of the money yet. So I know our team's been talking about the expansion.
Okay.
But it's also driven by the number of patients we have. So, right. So I think we're working with the state, the number of, because it's based on the number of Medicaid patients you serve. And so we're trying to figure out how to do that outreach to get more of those patients in the door. And we've been assured that the funding will be there if we can do that.
Thank you.
Great. So I'm going to alternate between House and Senate. So Ruth.
Thank you, Madam.
Sorry, I should say Senator Hardy. I'm much more informal in our committee. Senator Hardy.
Lori. Well, thank you guys, and apologies for walking in a little bit late. But I have two questions. First, similar to what Rep. Black just asked, in Bennington, they are starting a hub actually, and I'm assuming you're a spoke.
We're spoke.
Okay, and so have you seen any impact yet? I think they just opened or maybe are about to open the hub.
Yeah, so we haven't seen it yet, but we're working with, so the model, the Blueprint model in Bennington County is a little bit different. The funds go through the hospital. They're the employer for, to try to make it so that you have a full-time employee with benefits because we have such small practices throughout the region. And they're talking about placing a full-time community health worker with those funds at Battenkill, and that will be hugely amazing for our patients.
Okay, great.
The piece, Blueprint is an amazing program, and I would suggest never taking that away, please. But it doesn't change revenue stream, right? They're free services. It's amazing to have those wraparound services for our patients, but it doesn't get at the budget problem that we're seeing.
Yeah.
So yes, we're seeing staff and we're so appreciative for that.
Okay. And then I have a question for you. In Springfield, I didn't quite understand how you spun off from the hospital
Sure.
debacle,
Sure.
for lack of a better word. So was it the hospital practices that were associated with the hospital that became an FQHC?
Yes, after a very long period of time. And so a lot of these
Okay.
private physician offices, they weren't sustainable. So the hospital employed them all. And then the hospital became rural health centers for their primary care group.
Okay.
Then an FQHC. And the FQHC was positioned above the hospital. The hospital was a subsidiary at the time.
Okay, so the hospital is a subsidiary of the FQHC?
It was.
It
right.
was, but it is
Right.
no longer.
Correct.
The hospital still is a
The
hospital.
hospital is still functioning as.
But you're split now.
We're good partners, but we are no longer affiliated.
I see. Okay. Okay. And then I guess my final question for all of you, and maybe I missed this because you said it in the beginning. I hear you about the financial struggles, and that sucks, for lack of a better word. What is your ask of us today specifically? Besides, we need your help, but what, do you have a specific ask that you're coming to us with?
Yeah. Hand that over to Georgia.
Okay.
Hello, again, Georgia Harris from Bi-State. We submitted a letter to the appropriation committees earlier this week requesting $2.8 million in appropriations to shore up the Medicaid reimbursement so that Medicaid is fully compliant with paying their fair share for the cost of Medicaid services.
Okay. Do we have that letter as well?
I believe we CC'd the chairs.
Okay. It'd be great if we could get that on our website or have it.
Can you resend that?
Sure.
That would be excellent.
Thank you.
And obviously those are conversations we'll continue to have as.
Yeah, I just want to say it's a budget conversation.
Right.
We will not be talking about it in our committee until we see the budget,
Right.
but it's there. And we did get the letter and appropriations. So when you resend it, make sure it goes to 2 committees. That'd be great. Just one more question. Let's take one more minute.
Right,
For
right.
one last question.
Representative Rebecca from Winooski. Regarding your budget gaps, I'm curious, as the state, I know Department of Mental Health and some of the designated agencies have been exploring the CCBHC Certified Community Behavioral Health Clinics model. And
and those have a federal enhanced Medicaid reimbursement rate. I'm wondering if any of you are involved with that, since that model does have a requirement to collaborate with FQHCs. Are any of you involved? Is that at all a benefit to some of your challenges?
In Chittenden County, we have a really nice relationship between the community health centers and the Howard Center. And it is our hope that when they get to integrating with primary care, certainly they'll do collaboration with our primary care and our own sites. But we've also talked about down the road trying to envision integrating primary care into the Howard Center. So we're having those conversations and trying to plan for that. But as far as it's not at the moment.
And I would echo that for Springfield. We work very closely with HCRS, Healthcare Rehabilitation Services, and they're at the table at the Brattleboro expansion as well and how we can work together.
Great.
Can we ask Kayla to send her slides?
Can you send your slides to Claire Neal?
Yes.
So we can have them. That would be excellent. Thank you. Again, thank you all very much for coming early this morning. We do have testimony for the next couple of hours. And I know you're only in the card room until noon, but hopefully there'll be some time to have some conversations with us at the table later. And many of our colleagues hopefully will stop by the table. So again, thank you for all your work for Vermonters. It is vitally important. And
Thank you.
Thank you.
Thank you.
So I think we're going to stay live and switch to 167.
Go to 167.
Anyone over here was there?
Yeah.
Get this?
It's old.
Okay, I'll pass it over.
Well, it's just like 10,000 people. Yeah, okay. Like how, what do you want to put it up? That's my question. Yeah. What did you say? Yeah, you're right. Yeah, I agree. Very high? Yeah, okay.
That's fine.
My bad. I'm so sorry. It's okay. I'm going to get up and walk.
That's fine. Okay. Well, do you want me to start?
You can start.
So for folks who are sitting back there, there's chairs up here. If you prefer, you might be able to see the screen better when things get put up. So that's up to you. We're no compelling reason to move. All right. So thank you, House Healthcare and Senate Health and Welfare for being here. We're going to continue the meeting. Representative Houghton is taking breaks off and on to exercise. So she'll be back.
We all do that?
No. Actually, physical activity is good for all of us. So, feel free to stand up from time to time. I think that's important. Representative Lori Houghton, Chair of House Healthcare. I'm Senator Ginny Lyons, Chair of Senate Healthcare, Health and Welfare. And why don't we have House reps who are on House Healthcare, just raise your hands so folks can see. And then Senate is here. Senate will raise our hands. We're all, one is taking exercise. So that's good. So we're moving on to Act 167, and last year in the spring, we passed this bill, S-285. And we've asked Jen Carby to come in and give us a short reminder of what we passed and what's in the bill. And then we're going to look at the work that's been going on since the springtime that be around Act 167. And I'm not going to talk about it because Jen's going to do that for us and we're going to hear enough about it. But suffice it to say that there is a lot of work going on, and it's terrific, and I hope that we'll appreciate what we hear. So Jen, why don't you start us off and will remind us what we're looking at in Act 167.
Great. Good morning. Jennifer Carby, Office of Legislative Counsel. So just a quick reminder of what happened in Act 167 for the pieces you're going to be talking about. And this is Act 167 of 2022. So for those of you who are new in 2023, you didn't work on this.
Right.
But in Section 1, there was a requirement that the Director of Healthcare Reform in the Agency of Human Services in collaboration with the Green Mountain Care Board, develop a proposal for the state's next agreement with the Center for Medicare and Medicaid Foundation to ensure Medicaid participation in multi-payer alternative payment models in Vermont. There were a number of considerations that had to be taken into account in developing the proposal that were spelled out in the legislation, and also some specific alternative payment models to be explored. The development process had to have opportunities for meaningful participation by the stakeholders. So that was the first part of Section 1. Section 2, the second part of Section 1 was directing the Green Mountain Care Board to collaborate with the Agency of Human Services and use that stakeholder process to develop value-based payments, including global payments from all payers to Vermont hospitals or accountable care organizations, or both. And there were specific factors to be taken into consideration there as well. And there were reports due on each of these last January and March, respectively. Section 2 dealt with the hospital system transformation and engagement process, and directed the Green Mountain Care Board, again in collaboration with the Director of Healthcare Reform in the Agency of Human Services, to develop and conduct an engagement process for Vermont hospital transformation. And there were a number of factors specified. And what that was supposed to look like, with an update on the community engagement process last January. $900,000 was appropriated in the FY23 budget for the Agency of Human Services work, and $4.1 million for the Green Mountain Care Board's work. And then you passed a couple of provisions last year that kind of piggybacked on some of these. So there was a requirement in Act 51, which had been H206, on the responsibilities of the Department of Vermont Health Access and other provisions that effectively added a new section to Act 167, even though it wasn't in there when originally passed, that directed the Agency of Human Services to engage in transformation planning with up to 4 hospitals to reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services while maintaining sufficient capacity for emergency management. And so that went progress report due in February of this year to your committees. And in last year's budget, there was also a requirement that the Green Mountain Care Board submit an update to the Health Reform Oversight Committee by November about various things having to do with hospital performance and hospital transformation. So that occurred in November of this year at the Health Reform Oversight Committee meeting. And now here we are.
Okay, thank you. Good. So we're going to begin with the Green Mountain Care Board, and see you behind me. So all 3 of you want to come up? Okay, why don't we do that? If you need a spot to put your materials, can you share?
Share.
All right. Oh, you're good at sharing. So we have, do we have what you're presenting on our webpage, or is it something different? Oh, how do you want to go?
You should have a copy. We will share our slides and just take a moment.
Okay, we can put those up here. So this is the update from under Owen Foster's name, and Claire's putting it up. There's not putting up, she's putting.
She's putting it up.
Yeah.
Yeah. Always IT.
Apologies, why?
She's doing that. Do you want to do introduction?
Sorry.
I'm trying to join the Zoom and then I can just run the slides if that works.
Yep, that's fine. Right. You should be able to share now, Claire is saying.
Yes, we can see you.
In double. So great.
Just what you wanted.
So close.
All right, so now that it's up, why don't we have you introduce yourselves for the record, and we will listen to your presentation, information.
Great. Well, first, thank you, chairs, for inviting us and for the committee members to be here to hear us today. My name is Owen Foster. I'm the chair of the Green Mountain Care Board. I started in October of 2022, so I've been there about a year and a few months. I'll introduce themselves.
Morning, my name is Marissa Melamed, Associate Director of Health Systems Policy for the Green Mountain Care Board. I've worked with the board for, quite a while now, since 2016 on most of the different regulatory processes that the board oversees, as well as their special projects.
Great. I'm Elena Barabee, the Director of Health Finance of the board. I recently returned to the board after taking a few years to work on my dissertation and PhD work at Dartmouth in health policy and clinical.
Thank you.
So I'll give you a little overview of what we'll be discussing today. First, we're just going to give a reminder of who the Green Mountain Care Board is and what we do and what we don't have authority for. I'll speak a little bit about our process and then some general information about the state of the state in healthcare and how we're doing. And I think that's relevant context for the work that we're doing through 167, why we're doing the work, and then we can discuss what we're doing exactly in more detail. So the Green Mountain Care Board was established in 2011, and I wanted to focus on one thing here first, which is quasi-judicial. I'm a lawyer myself. Our executive director is a lawyer, and Robin Lunge is a lawyer. So there's two board members who are lawyers. But quasi-judicial, what it means is it has a judicial character or sort of some characteristics of judicial nature, such as like a court proceeding. And what we do largely is we review budgets, make decisions on budgets. And we do that by holding hearings and receiving evidence and having witnesses and receiving testimony. And our job is to evaluate that information and then to make factual determinations and conclusions based on the evidence that we receive. So this process is important because it helps us get at what is the best decision, right? We can challenge certain statements that are made to us, right? Everyone has context that's relevant to what they say, but there can be a broader context and that can influence a decision, right? So we're actually trying to think about the entire healthcare system. And I think one thing that the last presentation said was an ounce of prevention is worth a pound of cure. And that's something that's really top of mind for us. We have a lot of problems in Vermont with our prevention. We have inadequate primary care, we have inadequate mental health, we have inadequate long-term care. Those things help prevent illness. They also save money. So they're right from an equity standpoint and they're right from a financial standpoint. So when we're making decisions, some of the information we're receiving in those hearings that we're evaluating, we're thinking about it not just from the perspective of the entity that's before us, but from all entities that are in the healthcare system, and more importantly, from the patients, right? Because there's a lot of competing things. We have a very solemn duty. It's a hard duty. It's not that much fun at times. But what we do is people ask us for a lot of money, tens of millions, hundreds of millions, billions of dollars, right? So I think the last hospital budget cycle might have been about $3.5 billion or so requests. Those are gobs of Vermonters' money. And the rate requests, what those mean is how much money is being taken from ratepayers. All of your constituents, our neighbors, our friends. They're farmers, they're trades professionals, they're restaurant workers, they're everybody. And when you have a large rate increase, that hits them in the pocket. They have less money to do other things, right? Less money to buy good food, less money to go to the gym, less money to go on vacation, less money to invest in their business. So when we're asked to give a lot of money it's a really solemn duty. You have to take it very, very, very seriously. And so that's what this process is for. The legislature recognized this. In 2011, they set up this board with 5 independent members, right? And we're different. We have different backgrounds, different professional, educational backgrounds. And part of that, to my mind, is that we want people who, it's not one person, right? Everyone has a different view that we bring when we hear that evidence, different life experiences. And so it's not just one person, and it's not behind closed doors. In a public hearing, it's very transparent. It's apolitical. We're independent. We do not work in the executive branch. We do not get feedback from the governor. We do not get feedback from legislators, right? And that's a really good thing because we want somebody to be able to look at this information really objectively and make the best decision we can. So that's why the structure is what it is. It's interesting, while we're different and we have different views, this last year, I've been there 1 year, been through all the cycles. The amount of times that we voted together is overwhelming. Most of our votes are unanimous, even on the big substantive meaty ones. So if you look at the hospital budgets, we have 14 hospital budgets we decide, and there's 5 of us. Member Merman, he abstained from the UVM ones. He works at CVMC. I think the votes were 66-1. 66 votes, all exactly the same, 1 vote not, on 14 hospital budgets. So pretty uniform and consistent. On the hospital budget guidance, it was 10 votes. We had 2 votes on it because there's an appeal. 10 votes, all uniform. On rate review, 20 votes, 0 opposing. So while we come from very different places right now in this time in Vermont, we're seeing very consistent and similar things and recognizing that as a group that comes from these problems very differently, but we're voting consistently together. The only one where we don't is the ACO. On the ACO, I think we've had 2, maybe 4 substantive votes. One was 4-1, one was 3-2, another one was 4-1, and another one was 5-0. So again, pretty consistent, but on that one, we have had some more disagreement as to what the right course of action is, which isn't really that surprising, right? There's a lot of history with the ACO. There's a lot of expectations, some fair, some not. And so we have, that's a healthy thing. We want that. But generally in the big meaty ones, this group of 5 people votes together almost always. So what we're trying to do is make decisions, as I said, that really benefit the entirety of the system. And one of the decisions we made this last year, which I think was kind of under the radar, but I thought really important, was on our rate review decisions. And on those decisions, we put in a provision that said when insurance companies decide how much money to award to various people they're negotiating with, they have to consider affordability, access, and quality in those decisions. Because we want to sustain parts of the system that are affordable. We want to sustain mental health. We must sustain primary care, we must. But what was happening in Vermont was there was a very large disparity between what regulated entities were receiving in rate increases versus everyone else. And we didn't dictate, give them this, but what we did say was insurance companies need to be cognizant of that. And they need to think about that in their decisions, because if they're not, we're not putting the money where it needs to go. And so that's why we did that. And we'll see how it goes this year, and we'll see what the results are. On this slide, the one that I think is most important is accountable. We're a creature of the legislature. We are accountable to you and to your constituents. I think it's fair for the legislature to ask us, how are you doing on affordability? How is Vermont performing? And if it's your task and you have all these authorities, tell me what you think. Are you doing well? Or are you doing poorly? On access, same thing. We have huge access problems in the state to many different types of care that are really important. We need to be accountable to you and to your constituents as to how we're doing on access. If access is bad, it's not going to be all our fault, right? We're one part of the system. There's other parts that have other levers. But I think all of us collectively at this point in time need to be accountable for these things that Vermonters need. I'll give one anecdote that really resonated with me in my old career. I was a Department of Justice lawyer. I was a prosecutor. I did healthcare fraud cases. And one of my mentors said, there's people who make cases and people who tell you why. You don't want to hear from us and people who get paid to do this work why we can't. You need to hear why we can and how we're going to do it. not we're a small part, not we can't control this. We need to actually come up with solutions. And that's be accountable. So I expect those questions. I think they're fair questions and I think they should be asked. Another component of accountability is the transparent nature of our work. We have meetings, public meetings, almost every week. We had 53 last year. And at these public meetings, there's notice and anybody who wants can attend. And they've been remote since COVID, so you get people from all over the state who otherwise couldn't come to Montpelier, couldn't afford to drive here, couldn't deal with the hassle of coming here, whatever it might be. And they come in on the Zoom and have a time where anybody can comment to whatever they want. A regulated entity, a patient, anybody, people from out of state. People from out of state do participate. And it's really insightful, right? Because it's really important to get the whole gamut of information when you're making decisions. You need to hear from the patients. You need to hear from the businesses. You need to hear from the hospitals. You need to hear from the primary care. You just need to. And so this avenue that we have, this requirement that we have, gives us that ability. It's a really important mechanism to what we do. We also receive tons of written public comment, tons. So this last year in the hospital budget cycle, we had to start with guidance. We say what the targets are. And in that process, I think we received, there's an appeal to have us go to a higher level of money. And I think there was close to like 200 public comments we received. And they're really valuable, right? So there's a huge chunk from hospital board members, members of the boards of the local hospitals, and they shared their view as to why they should have a higher guidance level. And that was really valuable to understand why that money is needed from their perspective. But then there's a huge collection of people who had views as to like all the independents, the mental health, and everybody else as to why it should be lower because of the impact, the collateral impact a higher amount would have on them. And they shared that view. And then we had the patient's view of if you go higher, what is this going to cost us and how is that going to impact us? So that's just, that public nature of it is really, really, really valuable. I've said this before, but we all try and make sure we get out and meet with the whole spectrum of the healthcare system. Next week, I'm going to a treatment facility center. The week after, I'm going to another treatment facility center. I've been to a number of hospitals, many hospitals, a number of independent primary care clinics, and that just makes sure you're making good decisions. This is just sort of a slide that I've used before about the role of the care board and what we do and don't do, because sometimes people think we're all of healthcare. We're not. What we regulate are the insurance rate review, right? So that's really Blue Cross Blue Shield and MVP for their small group and individual group. We decide how much money they can charge. They'll ask for, I think last year might have been 17, 18%. And then we'll make a decision, look on all the evidence that we received in that quasi-judicial process, and we'll say, you know what? You didn't hit that standard. You didn't prove this much. You didn't prove this much. You're going to have a lower amount. And also beyond just with the evidence, we have to think about what this is going to do to Vermonters. Can they afford this? So that's that role. Certificate of need, that's, you know, just to ensure that there's appropriate allocation of resources and people aren't buying too much. There could be some recommendations around changes around that to expedite it. That's something where I think the care board can improve. I think we should handle some of these quite a bit quicker. Last year, my first year, we adjusted and made automatic the amount of money that would get captured. So now it's actually the max that it can be. So for us to have review, the trigger is the most money under statute that we're allowed to have it at. And it's automatically renewing every year based on inflation and other factors to how high it can be. So it's at the max that it could be. I think there's arguments that it could be even higher, or certain types of care could be not fall within jurisdiction of CON. So, you know, CON laws are written, but then there's changes in what we have in our healthcare environment. And so today, does it make as much sense to prolong and delay how long it takes for a treatment facility to come up or a mental health facility? There's arguments both ways, but I think that's an area worth discussion. Hospital budget, ACO oversight, I think we're all relatively familiar with what those are. There's a couple of things I'm going to highlight that we don't regulate, which are FQHCs. We don't regulate independent providers. We don't regulate ambulatory surgical centers other than CONs. If they're from a hospital, we do, but not otherwise. DAs, we do not regulate. Medicare and Medicaid, we cannot and do not regulate those. I go to a lot of meetings and people tell me to increase their Medicaid. I can't do that. We can't. Self-insured plans, Medicare Advantage plans, we have no regulatory authorities in connection with those. So affordability really matters because it means that it can have adverse impacts on people's health. People delay care when they can't afford care, right? They don't get primary care. They might not, they'll just avoid or delay care. They'll buy down on insurance. We don't want that. We don't want people buying down on insurance because of the financial decision they have to make. So we try to keep an eye on how Vermont is doing in respects to affordability. I hear people say, well, it's healthcare, it's not going to be affordable. I think those kind of broad brush statements don't really capture the nuance of what we're trying to do. Yeah, it's never going to be affordable. It's not in this entire country. But does that mean Vermont has to be the worst or near the worst? Or can we do better, right? And it's really about doing our best, not saying like, oh, forget that bucket. I think we have to tackle it because it has real impact on Vermonters. So this slide gives you some data. I've said this before and I'll say it again. Healthcare data is, to me, directional, and you need to test it from multiple angles. So in the hospital budget process, we had comparison data that helped us compare how much people are spending on admin costs, how much money they're spending on clinical care, how much it costs to discharge a patient. And any hospital system, they're very complex, might have different ways that they account for the money, which can change what those numbers really should be. But if you take every change, you now no longer have a comparison because everyone you're comparing it to may also have changes, right? So if you change everything for one place and you don't change every one at the other 100 hospitals, there's no comparison left. But it is true that all of this data may have some nuance to it. And so I think it's important to not look at any of these things as definitive of anything, but really directional and temporally over time. Where is it moving over time? This is our qualified healthcare plan expenses and where Vermont started in 2019 and where we are today. Bottom line is United States, the top line is Vermont. We started higher for a number of reasons. We don't have community rating as an issue, and what we provide for people, what we require in our qualified health plans is greater. So you actually get more with a Vermont plan than most plans in the United States, which is a good thing. So we start higher, and that's explainable. But then we go up quite a bit faster than the rest of the country. I think we grew out of 58.5%. The rest of the country was under 5% on average. So we're growing quite a bit quicker, more quickly than other parts of the country. Our spending per capita, we're a very healthy state. We're really blessed with an incredibly active population. We're old, that's true, but we're a very healthy set of old people. That should really keep expenses down. Healthy people don't cost as much. We're fortunate to have a very healthy population. So around 98, 99, 2000, Vermont was actually in line with spending per capita with the United States. We were equal, right? We were right there on average with the United States. Since then, we've expanded. That could be a good thing. It could be a bad thing. It could be some combination. You might want to spend more money on healthcare. That might be. We don't want to be Mississippi. They don't spend a whole lot. We want to spend more, but we want to make sure we're balancing it. So here you can see just where those lines start to diverge, and then how quickly our spending is compared to the rest of the country. I'll spend just a second on this one. This is total premium for employer-based plans, employer contribution, and employee, right? So you work, you have a job, your employer pays some, you pay some, and then there's a total amount. So the top line is Vermont, so here. The bottom line is United States. The top is the total premium. So our employer-based plans in 2017 were on par with the United States. We were consistent with the average of the country. Since 2017, we've grown faster than the rest of the country on our total premiums for our employers. And our employer contribution has also grown faster. Our employee contribution has remained relatively steady with the rest of the country. So our employers are paying more, our employees are paying less. It could be because of competition for employees here is tight. It could be our employers are more generous and they provide better benefits. We're concerned that this bottom line is going to start to diverge as we go forward. We've heard anecdotally that a lot of employers are starting to shift some of the financial burden as it's gotten particularly acute to their employees. So this could change. That's something to keep an eye on.
I just add also the nature of the plans could decrease, right? So it's not just how much you're paying, but what you're getting for it is often sacrificed.
Right. Healthcare costs show up in a number of different places. They show up in the state budget. They show up in our health plans. At the Care Board, and every state agency is seeing fairly large increases on how much we're paying for healthcare this year. It also shows up in places you don't really see as much in the press, which includes property taxes. So this year, there's a report. I think the number will hopefully go down quite a bit. But the average property tax bill is supposed to go up 18%, 18.5%. That will come down, I think. But that's a really huge increase on people's property tax bills. And a big chunk of that is because of school spending on healthcare. School spending on healthcare is going up 16% this year, it's expected. So people's property taxes are going up because of the healthcare costs. Insured rates and uninsured rates. These are another metric we kind of keep an eye on to think about whether or not we're having adverse consequences to increased costs. And you want a low uninsured rate, obviously, and you want a low underinsured rate. Vermont does very well on uninsured. We have a very low uninsured population, but then we have a very high underinsured population. That means they don't have enough insurance to cover and they can't pay for the care that they need. So I think about my brother. My brother's a carpenter and he's up on roofs. He's probably on a roof today hammering nails. And it's dangerous work, and he's on an individual plan, right? Actually, now he has a fiance and he's not. But other carpenters will be on individual plans. And I hope he gets married soon because he's been engaged a long time.
Hope he's listening to that.
On the record.
He's heard me say it before. In any event, there's a level of equity to how we allocate healthcare costs, right? Because people with high-paying jobs and like the lawyers and doctors and others have less risk to their physical safety than.
So can I just stop you there?
Yeah.
I mean, there is a perception that doctors have the high-paying jobs, but that is not categorically accurate, nor is it true for lawyers, but lawyers probably make more than doctors. We'll have to look at that metric and understand.
Fair.
It struck a note, sorry.
No, fair point. Relative to much of it's a fair point. In any event, some of the work.
There are people who earn a lot of money. We know that.
A lot of the people who earn a lot of money are not doing dangerous jobs. That's really my point.
Yeah, that's the point. You get it.
And their insurance plans are generally more favorable than those who have dangerous jobs.
Yeah.
Right? And so if you have an employer-based plan, you're not paying that much. But if you have an individual plan, you pay a lot, right? So a lot of the laborers have a very, very high insurance expense, whereas others with less risky jobs don't. And when you're trying to ensure financial stability for the system, what's happened in Vermont is a lot of that pressure has been put on commercial insurance, right? They call it the cost shift. And we'll debate that all the time. But in any event, much of the money that we need is coming from commercial. That pool of people is shrinking, which makes it even more difficult for them to sustain those costs. And as the costs go up, more people exit that market. It's not necessarily the most equitable way to appropriate those costs, right? Because it's not based on income. It's not a tax system. It's not progressive. It's kind of by happenstance what your job is, really. So anyway, our underinsured rate has been increasing. The underinsured rate over the last several years has been going up, which is something that we want to be mindful of. I'll go through these quickly so I can turn to these folks. But I want to touch briefly about our Medicaid spending per beneficiary. There's really three sets of money for healthcare: Medicaid, commercial, and Medicare. Our Medicaid spending is quite high nationally. We're on the higher end. Our commercial spending is on the higher end nationally. And then our Medicare spending is last. And from my perspective, that's not what we want. We want to pay less with Vermonters' dollars, commercial insurance and Medicaid, and we want to spend more with the federal dollars. And we have an aging population, so we're going to have more people that are being paid for by this money. And so we actually want this to go up. It's kind of confusing. How can you be so high on two measures and dead last on another? So we want this number to be more balanced. You can see we actually were going up quite a bit, and then around 2017, we were at $9,829 per beneficiary in Medicare, and then we dropped down, started going down, while the others started going up. So that's something we want to be mindful of in the Green Mountain Care Board's decision making. Real quick, so there's a finite amount of dollars is the point, and we need to allocate them correctly. And part of the allocation is kind of system-wide. How much are we putting in primary care? How much are we putting in mental health? How much are we putting in hospitals? But then within that, how much money are the hospitals spending on those preventative type services versus other services, right? So nationally, the country spends 30% of our healthcare dollars on hospital spend. Hospitals are a more expensive place to spend money. They provide some of the most important care, and it's going to be the most expensive care. In Vermont, we spend quite a bit more on hospitals than what you see nationally. We spend 47% of our healthcare dollars on hospitals. That might be a good thing. A lot of our hospitals, particularly today, are providing a lot of services that aren't available in the community, right? You've probably all heard about the boarding issue we have. And part of that is because they can't get the patients to an appropriate care setting, or the patients are coming in because they can't go to urgent care or primary care. So they're using the ED for that. So some of this could reflect that service that the care gap that they're filling. And some of them may provide different services than other hospitals nationwide. I'll turn to Elena after this, but we don't use our hospital system a whole lot. We have low utilization compared to national. So this is a national median of admissions per 1,000 residents. See, Vermont is way down on the lower end of the spectrum. So we spend a lot on our hospital system, but we access it less.
On a per capita basis, right? Yeah. And I think part of this is, so this is a chart, national database using Medicare cost report data that looks at hospitals' break-even points. So that is the amount of funding needed from a commercial payer in order for a hospital to cover their costs. The purple bar charts are for the kind of the national median, and the red bar charts are for Vermont hospitals by size, so number of beds. So what you can see here is there's quite a bit of variation, but on average, Vermont is much higher in terms of the commercial dollars that it needs in order to cover its expenses. That could be for this kind of rebalancing that Chair Foster mentioned before. So hospital adjusted expenses per inpatient day. So about, again, this is kind of the cost trend. So we were kind of below the national average, but have eclipsed the national average more recently. And so there are a variety of ways to think about kind of what you're getting for your dollars, and there's no perfect way of measuring this. One way is thinking about our mortality rates or access to care. So while we have lower mortality rates, as Chair Foster mentioned, we do have a healthier population in some ways, and our access looks quite good in terms of the number of clinicians that we have, but we still struggle really with wait times. And this is, a little older of a report, and we'd love to see this updated. But this is kind of a challenge of, we do have low utilization, but there's still a lot of Vermonters that can't necessarily get the care that they need when they need it. And that's part of the system-wide challenge that we're facing. And as we've been talking about, hospitals are just one setting of care, and they could be doing a lot of different things, but they really rely on the broader delivery system to perform their duties and to do that well and to serve patients. So we have, our federally qualified health centers and other community health centers, ambulatory care centers, extended care, and in the acute care setting. And all of these things really have to work together to have an efficient, high quality, high functioning system. One area that, we know that we have significant access challenges despite having a number of bodies available to us is Vermont primary care. And nationally, we are, depending on how you define it, this is the definition that is used to compare across states. This is not the same Vermont definition that we have in statute. But when you look at this national comparable definition, we're kind of in the median to lower half in terms of how much spending we have on in primary care. But when you look at the Vermont definition, that increases to about 10.2%, but it's hard to know how that compares to other states. So, it's a struggle. And just because we have more dollars doesn't mean that they're being used in the right way. So, dollars are one way of looking at it, but there's definitely a greater need to really understand what high quality primary care means and when it's happening. So admissions are decreasing, but the length of stay is increasing. So this, speaks to some of the pressures on hospitals and being able to transition patients out of the hospital into the appropriate care setting. There are a number of pressures that we've heard about through the hospital budget process and elsewhere. Skilled nursing facilities, mental health, housing, all of these things are very important and will need to be discussed and thought about. So we'll do a quick, I don't want to take up all the time, so I'll do a quick update here and then we can dive into, specifically at 67. So as you know, or may have heard, 2022 was one of the worst financial years for hospitals. This was after the federal funding dried up and volumes were still kind of coming back. And so it was a real challenge nationally. There were a lot of closures. But in 2023, at a national level, hospitals began to rebound, some of that volume came back and their margins look much better. At a system level, I presented a similar slide. Last time at a system level, you did see kind of a rebound, but I didn't have all of the hospitals reporting, so I didn't show you kind of the level of detail. And these are still in flux as they're still reporting their audited financials through the end of the month. But what you can see is that there is quite a bit of negative margins still pervasive across our healthcare system. And this is largely the smaller hospitals that are not part of health systems. With the exception of CVMC, the other hospitals that are in the black are those that are part of a larger entity and have kind of more fluidity in their funding to cover some of those costs. Hospital budget requests this year. So we set at 8.4% 2 year, 8.6%. NPR, so the net patient service revenue, so that's kind of the whole budget that you will be accepting or all the revenues you'll be receiving from patients. And the requests came in at 19.3%, so it's a 2 year rate. Commercial price was around 9.84%, and the operating expense growth assumed in these budgets was around 5.71% at a system level. We compared some of these commercial rate increases to a variety of inflationary factors to try to understand, how reasonable this was relative to what Vermonters can expect to pay. And it was quite a bit higher. You have the Medicare market basket, at 3% median household income in Vermont at 3.9%, relative to the system-wide hospital rate increases of 10.6%. And this wasn't an exception to the rule. I mean, this is a trend that's been ongoing and it's a real challenge for the board and for hospitals, frankly, to navigate. And this has real implications for the rates. We see this in our QHP rate review process. Cumulatively, this is showing rate increases cumulatively over time. So from 2019 to 2024, we have 60 to 80% growth in rates, which is huge and really affects how people can engage with the healthcare system. And the board does its best to control that rate growth, but there's really only so much you can do when you're juggling kind of affordability on one side and provider solvency on the other. Nationally, the rates have been increasing, and some of the rates around 6.5% are staggering in other states, and ours are well beyond that. And it has, as you mentioned, real implications for families, what they get for that money, and then what that means to them in their everyday budget. Yeah.
There's also a sustainability challenge with that. Right? So the statute that we are charged with executing says that we should evaluate Vermonters' ability to pay for the care. That's one of the factors we're to consider. How can we afford it? And so if income is here at 3% and rates are 10 or 15, you can do that for a little while to keep it going, but over time, you can't. And that, I think, is part of why we're at 167 of how do we need to transform the system so we have an optimal allocation and using the resources as efficiently as we can, because it just can't work. Eventually that collapses.
So that said, we were able to make some reductions to the commercial rate this year, so the amount of 7.8% across the system, so 145 million, but this is, perhaps not sufficient to make care affordable for Vermonters. But we also recognize the challenges that hospitals are facing in terms of their inflationary pressures.
So you go back to them.
Yep.
So this is it was a 2-year guidance period, so we considered the fact that what hospitals got last year in conjunction with what they were asking for this year, right? So 2 years, that's what we looked at. Last year, fiscal 23, there are very, very, very large rate increases, I think in part because of the board's concern about sustainability and keeping our healthcare system going. And if we were too aggressive with the levels of rates, it would have been very towards the hospitals. This year, so they had a year of planning with large amounts of money. And this year, there were lower increases than the year before because much of the money was taken up the prior year. That being said, I was counting it before we started. I think 7 of the 14 hospitals received the budgets they requested, the rates and the NPR. 10 of the 14 hospitals received within 2% of the rate increases they asked for. So 10 out of 14. And then 4 had cuts larger than 2%, reductions from what they asked for. And each of those had asked for more than a 10% rate increase and had received large rate increases the year prior. So you can see some of our decision-making around that. The other thing is NPR, that total amount of money that they can bring in for patient services, that's NPR. We went well above guidance. Guidance was 8.6. For the most part, I don't think we adjusted NPR other than a small amount on maybe 2 hospitals. Some of my thinking as one board member on that was that we have access problems. And so if you keep the rate at a more affordable level, but you allow for the services to increase, the hospitals can make the exact same amount of money, right? More volume to address our access and backlogs and wait times, less money for each service nets the same amount of money they asked for. So we're trying to drive that access while balancing the affordability. So that's what some of these decisions were, at least for me, predicated on.
Great. Yeah, so this just shows that basically the NPR remains largely.
Net patient revenue.
Net patient revenue. Thank you. Net patient revenue remains largely untouched.
We have an acronym list in our committee, but it's not with us, so there might be some folks around the table. Just
bring some with us.
Name tags.
Yes. So largely untouched, I think, for these reasons, because of some of the access challenges and wait times. We would like to see better throughput through some of our providers, and so the board has largely left those, with the exception of when hospitals come in with utilization assumptions that are wildly different from what we see in actual. Sometimes there may be an adjustment to reflect what we realistically expect. We don't want to overestimate what we think might happen. So I know you spent some time, but I'll just really brief history of Act 167 from the board's perspective. This work is not new. These trends are not new. Rural hospitals have been struggling and small hospitals have been struggling for quite some time. There have been 191 closures since 2005 and 148 of those since 2010. And this has only been exacerbated by the pandemic and other kind of challenges to the way that we pay for healthcare. And, this has largely affected those, smaller hospitals that don't have reliable funding sources. So Vermont hospitals were no exception. We, observed these declining margins over time. And as we mentioned, this struggle, this tension between solvency and affordability with, as discussion this morning, the bankruptcy of Springfield Hospital was really concerning to the board and to many of you who were around then. And so the board had been kind of discussing, how much can we do with our current process that really puts this tension right in front of the board. How much are you going to add to commercial rate, or how much are you going to add to the hospital, financial challenges. So this really requires a system solution. And this was, kind of discussed within the confines of the Rural Health Services Task Force. You passed Act 159, asked the board for recommendations. We provided recommendations, and then those recommendations served as a basis for some of the language in Act 167. So just as a quick reminder, the board suggested the design and implementation of hospital global budgets to provide more flexible and sufficient equitable funding to hospitals, and a health systems optimization expert to facilitate community engagement, so we could think about what we should deliver where based on the needs of the population and how we could do that more efficiently improve quality and access, and then providing the resources necessary to make those changes. And that was really, we're very thankful for the Act 167 work and the funding that you appropriated for this purpose, because we think it's one of the most important things that the state has done in recent years.
Can we quote you on that?
So I just, we kind of organize it, and you have these two sections, but we organize it in these 4 buckets. And specified leader and follower, I think, as well in the statute. So the subsequent all-payer model agreement led by AHS and the Director of Healthcare Reform. GMCB was to lead and collaborate with AHS on developing value-based payment models. We were going to evolve our regulatory process. Some of that work had started just prior to Act 167, and then the community engagement work, which has been a real eye-opening experience for us at the board. So now we'll dive into the meat of what you asked us here today, but I'll turn it over to my colleague, Ellen.
And thank you for the opportunity. I feel like that was all an exceptional and comprehensive setup for the exciting work that we're doing on the community engagement piece, which is where the legislature gave us the opportunity to go into communities and talk with our friends, neighbors, colleagues in each community in Vermont to gather feedback on the current state of the healthcare system, not just through all these numbers, but through the actual lived experience of people in our communities, as well as start to look for solutions. So in my current role at the Green Mountain Care Board, I serve as the project director for the community engagement work. I'm going to walk you through a couple of slides on the progress of that project, which completed its first phase at the end of November. So it's a good place to give you a status update. So first, I want to introduce you to the Oliver Wyman principals that we hired to help us complete this work. Many of you may have already met them through the planning and community meetings that have happened so far, that started in the summer and the fall. So this work at Oliver Wyman is led by Dr. Bruce Hamery, who is a clinician, leader, and facilitator with over 50 years of experience in healthcare practice and systems. He has 3 years of experience in Vermont as well. You may be familiar, and it was cited earlier, the Health Services Wait Times Report from 2022. He led that work, as well as the COVID data modeling with the Department of Financial Regulation. He is located in central Massachusetts, so not terribly far away, and is planning trips up here to Vermont, meet with hospitals, community members, and lead our second phase of meetings, which will be in person. So if you haven't had a chance to meet him yet through some of the virtual meetings, you will have another opportunity, plus he'll be here in person. As well, this work is led by Elizabeth Sutherland, the second principal. She brings an expertise and was brought into the project with Oliver Wyman because of her expertise in state health equity through her most recent work identifying health equity zones in the state of Pennsylvania, where she is located. And she will also, they also have a team that supports their work at Oliver Wyman. So I'm really excited to be working with them and hope you all get a chance to speak with them directly. So this project contract started in August, and it ran through several months of engagement plan development. So these are roughly the phases. The first phase that ran from August through October was specifically to plan how the engagement was going to be done. So there was a round of meeting with stakeholders all across the state, many of whom may be in this room, who helped us actually plan out how the engagement and was going to happen and give feedback to the Oliver Wyman team. They were targeted to community members at large, providers, members of diverse populations. And they presented a couple iterations of the plan, the Oliver Wyman team did. And we worked with our partners at AHS to approve that plan so that they could then begin implementing it in October, which was the first public phase of the plan, which ran from October through November. And that consisted of meetings out in the communities done virtually, which were focused on specifically community members at large and providers. That ran about 6 weeks. Those meetings, I'm going to go through sort of the numbers and the stats of how many people we spoke to during that time. It was a bit of a condensed timeline, but I think it generated a tremendous amount of publicity with help from all the legislators, all the stakeholders we work with who helped get the word out so that people came. So I think that 6 week timeframe really made it that there was a lot of attention on it during that period of time. And those meetings wrapped up at the end of November. The current stage we're in now through March is the data synthesis and analysis, where the Oliver Wyman team will use the data collected from the listening sessions, so the qualitative data, as well as relevant analysis of health system claims and hospital discharge data to inform preliminary options and recommendations for hospital systems. So we're in that phase right now. They're working through a data analysis work plan, and we'll begin scheduling community meetings. They'll start the scheduling process in the next month or so, and begin those community meetings later in the spring. This is a timeline that's been pushed out a bit since we addressed the Health Reform Oversight Committee at the end of November. So for people that heard that, I think at the time we said this was ambitious. We discovered through the data analytic work plan process, the availability of data, that the work would be able to be done better if we could push the timeline out a little bit, and there didn't seem to be a reason to rush anything. So the community meetings are going to start more, we're looking at now, May, which hopefully for legislators will allow you to participate a little bit more easily. So that might be helpful.
So let me ask you the quick question on the March date. If we were to ask to have some preliminary report or report of the data analysis in March?
So it won't be ready in March because they are still working through the data analysis. What I am gonna, what we do have now is some preliminary sort of findings from those community meetings. And Dr. Hamery is actually coming to the Green Mountain Care Board meeting on January 17th.
Right, next week.
And he's going to talk about that. So that's what we have available now.
What about March? I mean, just thinking about two committees getting together and listening to the preliminary report.
On what the data is showing?
Yes.
We can talk to the Oliver Wyman team and see what they might have available during that period of time.
Thank you.
Sure, yeah. And ask him about it on Wednesday as well. So I think that probably covers, so the round two meetings, again, we have spring 2024 here. We're looking at having those actually start and happen in communities in May. You can go to the next slide.
This one. It's not going to be released unless it's due.
Okay, so we were really pleased with the numbers of people and the organizations that were engaged. And I think this is really a testament to how involved stakeholders were in legislators in helping us get the word out to get people to come to these meetings. Also, we made the decision to have them done on Zoom for this round so that it would increase the accessibility for people to be able to join. We also listened to feedback about the best times. Most of the meetings were held in the late afternoon or evening, specifically for providers, so that it wouldn't disrupt people's workday. But also we found for many community members, those later afternoon or evening times were just better in general. It's impossible to find times that are good for everyone, but most of the meetings were held from 4 to 6 p.m. or from 6:30 to 8:30. But then we also held several meetings at different times at 9:30 and I think 11:30, so that people had the opportunity to join those. And it generated a lot of participation. I want to highlight a couple of things on this slide. We had over 1,800 participants across all stakeholder types and meetings, so across the community and provider meetings. The initial phase of the engagement planning, we held 16 meetings with 91 participants. So that was just for planning the process and making the plan. And then we moved into the community and provider based meetings, which you'll see, which I can walk through the numbers here below. But on average, there were approximately 52 participants per community meeting, including the statewide meetings. So that I've been through a number of stakeholder processes in my time with the state of Vermont, and this seemed like exceptionally good participation. And over 100 organizations were contacted for their input and to get the word out that these meetings were happening. The Oliver Wyman team sort of broke these numbers down for us into these different groups. It's not necessarily clear who kind of fits in where, but I can kind of walk you through and let you know what each of these categories are. The team met with hospital leadership and boards directly. So those were 28 meetings with 235 participants. There were meetings with diverse populations. This is the work that was led by Elizabeth Sutherland. So she was doing sort of a concurrent process specifically to outreach to groups that are more difficult to reach, back to the equity and inequality conversation from earlier. Also, I'd make a point there that our board meetings are very open, transparent. People come, people comment, but that's not the same as going out and trying to reach people where they're at. People come who have a specific interest, they make comments. But there is a specific focus on this project to go and try to meet communities where they're at. So these meetings specifically, the diverse populations, it was with organizations, it was with the state's Office of Healthcare Equity, and then there was several meetings that were organized specifically to reach disabled population, as well as with the organizations serving mental illness. And that generated, 13 total meetings and 96 participants. Our state partners with 12 meetings and 18 participants, those were specific meetings with different state agencies and departments that would have, a particular point of view on these issues and questions. Includes obviously the Agency of Human Services, who we've worked in close collaboration with, Department of Health, Department of Mental Health, the EMS office, and State Office of Rural Health. The community leaders groups, that was another bucket that included Vermont NEA, the VSEA, Vermont Federation of Nurses and Health Professionals, and Vermont Business Roundtable. So then we get to the community meetings and the provider meetings. These were held in all 14 HSAs around the state. So we covered the entire state. There was both a community focused meeting and a provider focused meeting organized specifically to get clinicians. And that is, all types of clinicians. So there were 18 community meetings. So that's the 14 HSAs plus 4 statewide meetings. There were 931 participants in those meetings. The provider meetings directed specifically to people who work providing healthcare services directly. There was 14 meetings with 460 participants, as well as specific provider interviews and other sessions. There's 15 of those with 128 participants. We had at each of the meetings, we also had participation from Green Mountain Care Board members so they could hear the input. We had coverage at each meeting from board members as well as staff working on the project. The Office of the Healthcare Advocate participated in probably every meeting, as well as worked with us significantly through the engagement planning process and provided input. And I'm probably left groups out, but we do have an extensive list of all of those organizations and others who participated. And the Oliver Wyman Institute did these counts for us. Dr. Hamery and Elizabeth Sutherland facilitated each and every one of these meetings with help from their staff. So they were extremely busy during this 6-week period, doing 2 or 3 meetings a day, which was possible through the virtual platform. Go to the next slide.
I just want to comment, that's really outstanding work, connecting with all those people and organizations.
Yeah, thank you. We're really proud of it. The team worked really hard. It's really wonderful to be able to speak with and feel like we brought so much of the healthcare system together to provide their feedback. So like I said, this is really, I really only have a basic high level key themes from the round 1. Dr. Hamery is going to come and present directly. I think it'll be better to hear it from him directly to the board, so we would invite participation in that meeting. But at a high level, community members and providers reported both challenges and bright spots within these key themes. So I know there's a lot of difficult statistics that we've gone over today, a lot of things that look sort of bleak, but people also brought bright spots, particularly, stories around exceptional care that they've received at Vermont hospitals and from Vermont providers. But there are a lot of challenges, as we know. So those themes are organized into the categories we have here. And this is sort of the way that Dr. Hamery and his team will kind of start looking at solutions. But it's around hospital and provider operations, coordination between organizations, transportation and infrastructure was a huge area, workforce, financials, patient-centered care, healthcare services. None of this is a surprise. This is all going to be familiar. It's issues that you are and we are already working on. I think the important thing here is that this process really brought the community together to talk about these issues, and that is the focus of what we're trying to do. So again, this qualitative and quantitative data will inform the round 2 conversations, which will be bringing actual options and recommendations to the communities directly, and that's the later spring work. So then next, I think my final slide is the next steps for the community engagement work. So as Dr. Hamery and his team are working through the data, he is going to bring back to the communities options for their local areas. And again, the important thing here is that he's bringing these options back to the hospital boards, back to the communities. It's not you have to do this, you must do this, or the Green Mountain Care Board is going to tell you to do this. It's here are some things that you can do. I think of it as sort of this Act 167 work has provided sort of technical assistance for these communities to start looking at things that they can do to improve sustainability. So he's going to bring those options directly to the communities in the spring, talk with hospital boards, talk with communities about them, gather their feedback, and then turn that into a report back to the Green Mountain Care Board on what he has found. And then we can go from there in terms of solutioning. It could be thought of as things that the legislature can do, things that the board can do within their authority. Also, things that could just be implemented within communities without any type of action. So that is the exciting work that we have ahead of us. I'm really excited to be working on this project and have this opportunity to talk to you about it today. And that concludes my remarks.
Great.
Thank you.
Good work.
One thing I would say about the recommendations and the types of options, they're going to be pretty diverse. I think there'll be discussion about identifying care gaps and what we need to add systems. There'll be opportunities about there will be some things that the legislature could be involved in helping for solutions, such as licensure issues or regulatory issues, whatever they may be, that are beyond just money, right? There are so many other things efficiencies, EMS, all of the transport, all these things work together. So that I think there would be a pretty wide spectrum of things that we can address to start tackling some of the challenges we do have. And thank you for recognizing how great the work's been.
Yeah, it's been great.
So just another question regarding the timeline. Having the options available during the summer, it would be helpful, maybe this is just a message, helpful if at all possible when we have folks in March, that we get kind of an inkling of what some of the options may be. And I understand the analytic process, so it's not always simple.
Great, so we'll move on to the next section. Just developing value-based payment model, including hospital global budgets. Oops. I lost my Zoom connection. You guys can still see it.
Go ahead. Senator Weeks has a quick question.
While you're doing your IT, can you just give us an example of what the range of options might be, or just a couple examples of what options would be?
Yeah, well, let's see. I have, I have sort of broad categories, but so far, I know the team has been looking at, they can be areas around service addition recommendations, service transfer recommendations, service avoidance recommendations, intra-HSA collaboration. I know there's some of that going on now. There could be more areas for that. Those are kind of some of the high-level categories that he's given us. I don't have more specific recommendations that I don't even have them myself. So.
Before you continue, we also had one question a while ago. Mari Cordes is online. Mari, did you still have a question?
I do. Thank you very much. This is about the community engagement and the list of folks that were involved in this outreach, including provider meetings, state partners. Were pharmacists, whether hospital-based, community-based, independent pharmacies, involved in these conversations? And I'd like to have further conversation about making sure that pharmacies and pharmacists are involved as really critical partners in community health, and potentially an add or an addition to meeting gaps in communities where they might need healthcare provider access and there's no clinic. Pharmacies may be able to fill some of that gap.
That's a great point and a great question. I believe that the association was, but I'll double check that for you. It's not on the list that I have in front of me, but the list I have in front of me is not exhaustive of their full contact list.
Thank you.
I wasn't sure if we were asking questions now or not, so I didn't raise my hand.
So I think what we'll do is if there's a question of clarification on the Act 167 community engagement, we'll entertain those and then we'll try to move on because we have a hard stop at 10:30 and we want to take a short break prior to that time. So,
okay.
You have a question? Go ahead.
I just would love to see the full list of the organizations that you participated with. I had made a number of suggestions early on, and I wanted to know if they were followed up on. And I participated in several of the community engagement things, and some of them were awesome, really great conversation, and some of them were not. And some of them were frankly they were a little bit hijacked by what I will call hospital plants of people who went and sort of tried to steer the conversation into their direction. So I mean, I'm assuming that Oliver Wyman is professional enough and experienced enough to sort of recognize that and deal with that kind of, shift in the conversation. But I just wanted to know if that's been part of the conversation of sort of how do you deal with that? And there were a number of people who I suggested send written comments to, and I know that you've got a lot of those, and that's going to be part of the analysis too.
So I'm going to suggest that that's a great question, but that's a question we can get an answer to, maybe probably through the appendices when the report comes out, but maybe beforehand you could share with Senator Hardy and others.
Do you want me to respond to that now or hold?
Yeah, let's hold. That's a different question. We'd have to go through the whole list. And is there a quick answer?
Second part, I could respond to.
Yes, that one you can do.
So I recognize that. Great point. They were open meetings, so anyone could go. And there's certainly a challenge sort of in making sure that we can sort of pull in the full community and not just people that are already engaged.
Yeah.
So I'll take the opportunity to say that there's a whole other set of meetings sort of happening that were being facilitated by Elizabeth Sutherland, where she did more targeted interviews directly with communities. There was specifically a very successful one with the disabilities community where they organized their own meeting for that community specifically and made it easier and more accessible for people to come. So it's one way that we address that. And you're right, we don't have the written comments, the numbers of written comments, but we received an incredible number, which I can get the exact number of either people sent in follow-up written comments, things that they said at the meetings, or just people that couldn't go to meetings sent in comments. And those are also would be part of the analysis as well.
Well, but it is a concern that there's some redundancy and people are traveling around the state to make the same comment in other parts of this geographically. And one of the goals was to have a geographic understanding of community needs. So it is a real issue and you've addressed it somewhat, but it's something we probably want to hear about going forward. Okay, thank you. So back to.
I will try to speed through the rest in the next minutes. So I won't read through your language, but you directed us to design a global payment. I just want to kind of recognize that in order to design an all-payer global payment for hospitals requires Medicare's participation. And the opportunity right now to engage with Medicare is through the AHEAD model, which you'll hear from our colleagues at AHS on more detail. But that was really the starting point for the Medicare portion. So the GMCB staff have been working with AHS and the Director of Healthcare Reform to lead the Global Budget Technical Advisory Group to solicit input from a variety of stakeholders in anticipation of the release of Medicare's payment model and methodology. So we still don't have those details. So we have some insights about what it could look like, but there's still kind of this black hole of understanding. So members included representatives from hospitals, payers, unions, advocates, and others based on their technical expertise. So this is really kind of like a how would it work exercise. And the charge was to make recommendations for conceptual and technical specifications for a Vermont-specific alternative to the Medicare standard methodology. So we anticipate federal limits and guardrails to any methodology. So, we certainly have one view of what we think they might be willing to accommodate and have been trying to kind of work through that. So there have been meetings approximately every 3 weeks for 2 hours since January. And, all of our materials are posted publicly on our website, so you can kind of follow the slides and the content areas. So they covered a variety of topics, so including defining services to include in hospital global budgets, populations, commercial payer participation, provider participation. So should it be mandatory or voluntary, or how would we engage either of those groups? Calculating baseline budgets, that you, kind of what you would start with in terms of your overall revenue that you would take in, and then how would it grow? What kind of adjustments might there be to the budget? And then, thinking through how that would work with regulatory processes, a second step. And then transformation, administration, and valuation. So all the other things. So what would a hospital need to do to be successful under such a model? How would we administer it and then evaluate whether it's working? So where we are kind of headed next, so the global budget is kind of, or global budget tag and those technical recommendations are kind of being wrapped up. We expect Medicare to release their payment specifications in February. And then there will be some hospital-specific modeling about what the Vermont model would do for them, and then a comparison between the Vermont-specific model and the Medicare specifications. We are also beginning now, because this was largely led by, thankfully, Board Member Lunge with her expertise and AHS and some of our staff, but to start engaging board members who haven't been kind of involved in this process to help them understand kind of what we've learned, and then public engagement. So there'll be a variety of public presentations on the work that has been happening. In terms of evolving our regulatory process, so as part of this legislation, you asked us to recommend a methodology for determining the allowable growth in Vermont hospital budgets, decide how to, or determine how to best incorporate value-based payments or global payments into the board's regulatory process, and consider the appropriate role of global payments for Vermont hospitals. So does this make sense, and how? So resolving these three, we haven't figured this all out yet because there are a number of moving pieces to consider. It requires understanding what can be negotiated with Medicare, but we are already kind of thinking about evolving our regulatory process with or without, I should say, in anticipation of, or as an alternative to. But a brief history of hospital budget regulation. So we've actually had hospital budget regulation since the 80s. It's looked quite different. So it turned into Vermont Healthcare Authority, and we had BISHCA, and then the Green Mountain Care Board more recently. But this is not a new process. Why regulate hospitals? As we mentioned before, hospital expenditures make up nearly half of our spending, and is growing kind of exponentially compared to other states. Vermont's healthcare system is also highly concentrated, so we have a non-competitive monopoly market. Some Vermonters don't really have an option to go, beyond their community hospital. Some have more capability to kind of pick and choose where they can go and can leave the state, but this is really a matter of equity and making sure that all Vermonters have access to best quality care, or have, access to care at all. So as I mentioned, the board was already kind of thinking about, we kind of adopt this continuous improvement framework every year. We're learning. And so, before the passage of Act 167, we started thinking about establishing objective metrics for hospital financial health, improving the evaluation of delivery system and hospital performance. As we mentioned, hospitals are just one piece. A lot of what we observe through their budget process is other parts of the healthcare system. So parsing that out is often quite challenging. But there are ways that we can do that and get data and measures to help us understand what's happening. Alignment of our regulatory processes, particularly hospital budgets and rate review. This is where that tension kind of exists, how much we end up paying for insurance and rate growth versus growing hospital budgets. And then we would like to increase the consistency and predictability of our regulatory process. I think COVID was a particularly challenging year, and kind of recognize, give space to the delivery system to do what it needed to do as quickly as it needed to do it. And now we're trying to kind of pick up the pieces and figure out where we are going next. So we're always looking to minimize the administrative burden. That doesn't mean we don't want data or want to know what's going on, but we want to make sure that we're asking for what we need and that we understand, the whole system over time. And so that is a challenge, but as technology improves, it's much easier to kind of, when I think of administrative burden, now it's not the amount of data, it's how often you change what you ask for. So I think if we can kind of move towards standardizing and then kind of, there's ways to automate the actual reporting, we shouldn't be reporting less. We should provide more transparency, just more predictable.
So this was our first year with this new regulatory process with benchmarks. The whole process was really focused around benchmarks, comparing hospitals to like hospitals, academic medical centers to other academic medical centers, small regional hospitals, community critical access hospitals to others, right? And so you can see, are they starting really expensive? Are they asking for huge increases? Is there a reason for it? And so that judicial process I spoke about earlier, that's what we're doing. They have to make a case, we evaluate it, we look at how expensive they are to start, how much are they asking for, does this make sense in context of what we're seeing? So the benchmarking really, really helps do that. So this year we put it in the guidance in March, which we voted in March, that said here are the various benchmarks we're going to be looking at. And then this was Sarah Lindberg, our former director. We owe her a huge nod and appreciation for her really advancing this. We're really fortunate to have Elena step in and take over totally seamlessly. But in terms of like the resources allocation, I spoke about that earlier. It's for us too. How much burden are we putting on a small hospital like Gifford, right? The hospital's small. Their asks are not as big as UVM. UVM's a much larger, more complex system. I think you saw in this regulatory process, we spent a lot more time looking at a larger ask, larger financial asks than we did smaller financial asks. So the 7 hospitals that were approved as submitted, those were pretty quick and painless and easy. 2 hit guidance and were quickly approved. The other 5 were pretty easy too. UVM's ask was much larger and it's a more complex system, so it took more time and we spent it. So CON, we want to make sure we're putting the right amount of time of ours and burden on the regulated entity hospital.
So I'm very aware of our time. So if you can get to a good place, it would be great.
We are there. So I won't reiterate, we set this, for the first year, I think, capped commercial rate increases, so that I won't get into the technicalities of it, but we had, we finer level of detail, lots of work to continue to make that connection with affordability, but there was a significant improvement in using data. And not all data is going to have a one-for-one adjust, we're not going to use data there's no formula, right? So there's a lot of data, none of it's perfect, but it can help us understand directionally what's happening. This year, we're in the throes of it right now. We're kind of starting our first draft of guidance and we're going to expect to set more benchmarks, financial health. Net patient revenue has been one that we've relied on, but really focusing on commercial prices, operating efficiency, and financial health, and balancing these targets. Yeah.
With an eye to how important our community engagement process has been, is this an iterative process with hospitals so that there is an ongoing discussion?
Yes.
Good.
So actually in our rule, February 15th, we have to start, what are the targets that we'll be thinking about? And so we are engaging in those conversations. And then, while the Act 167 community engagement recommendations will just have been coming out, we wouldn't expect the budgets to look substantially different because hospitals won't have had time to digest that. But we would love to hear from them on kind of what they've learned and what they think, is coming and what they'll be thinking about. So I'll turn it back to Sarah Foster. It's our last slide. So.
Just want to thank our team and Julia Bowles for putting together this material for the committee for having us. Sorry.
We have noise back here, so it's just got really hard to hear. So I think you were just saying thank you, but if there's more, we need you to speak up.
To these guys and Julia and
Oh, thank you.
Yes, yeah.
This has been a terrific overview and background, historical context for us. And those of us around the table understand the work that's been going on over many years, but we also understand our role and your role, and we'll continue to work together with this. Thank you very much.
Thank you.
So at this point, we're going to go offline for 5 minutes and take a little break.
How about 10?
We're going to go offline